You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is August 16, 2024. We are doing our orientation series and we will be discussing pulmonary function testing in children. This is presented by Dr. Christopher Oermann. He is a professor of pediatrics and is the division director of allergy, immunology, pulmonary, and sleep medicine at Children's Mercy Hospital in Kansas City, Missouri.
It's going to be Dr. Christopher Oermann. Dr. Oermann is a professor of pediatrics at UMKC and works with us at Children's Mercy. He is the division chief of allergy, immunology, and pulmonary sleep medicine, and that's all equating. He's my boss. With that said here, he's going to speak to us today on pulmonary function testing in children. Thanks, Dr. Oermann.
Thanks, Chris. So I am the division director of a bunch of things, but I am a simple, old-fashioned pediatric pulmonologist. I have no pretenses about being an allergist, an immunologist, or a sleep doc, so we'll get that disclosure out of the way. So I'm going to talk today about pulmonary function testing in children. And sort of the outline I'm going to follow today, I'm going to talk a little bit about anatomy and physiology, but because it helps to understand some of the things I'm going to talk about subsequently. I'm going to go through the 5 W's of pulmonary function testing, as well as an H, which is very important. I'm going to talk specifically about spirometry, bronchoprovocation testing, as well as a few other odds and ends that I get excited about. So starting with the anatomy and physiology. Respiratory tract obviously divided into upper and lower sections. The upper respiratory tract is the nasal and oral cavities, the pharynx and the larynx. Primary job is filtration, humidification, and phonation. Lower respiratory tract is then divided up into 2 segments, the conducting airways where gas exchange does not occur, and then the acinas, which includes respiratory bronchioles, alveolar ducts, and then alveolar sacs and alveoli themselves where gas exchange does occur. So again, upper respiratory tract is those 3 portions, nasal and oral cavities, pharynx and larynx, and again, warming, humidification, as well as importantly, filtration. A lot of particulate matter in the air, as well as infectious agents, can be transmitted through the upper respiratory tract into the lower respiratory tract whereas you all know that is where we get into troubles with atopy and other problems that Chrissy kind of addressed today. The other important functions of the upper respiratory tract is the closure of the glottis, which allows effective coughing and clearance of material from the lower airways. So then the lower respiratory tract, again, we've got several different generations of airways, which is the way we think about this as pulmonologists. We've got the trachea, which has specific genetic as well as, or not genetic, anatomic as well as physiologic structure. The next bifurcation is the mainstem bronchi. Then we get down to bronchioles. And you know, the specific anatomy and physiology of these is not really important for you guys as allergists. We continue down to the respiratory bronchioles where we do start to see some gas exchange occurring. Then we get into the alveolar ducts, which terminate in these large alveolar sacs with lots of individual alveoli present. Do want to just mention the alveolar structure and function for a minute. Mostly type 1 pneumocytes are large flat cells that actually allow gas exchange to take place. They comprise 40% of the cells that are down there, but 90% of the total area of the alveoli. Type 2 pneumocytes, on the other hand, are smaller, very metabolically active cells that are much larger percentage of the cells that are down there, but a very small percent of the surface area. And then the other thing that's important to mention, it is not shown on these cartoons, are alveolar macrophages, which are cells that run around the alveoli gobbling up all sorts of things, including allergens if they get down that far, which they're not supposed to. So turning to the actual topic of today, that's pulmonary function testing, and going through those 5 W's. So the first question is, who can or should undergo pulmonary function testing? And there are multiple ways to address that question. Certainly age is a consideration. There is something called infant pulmonary function testing, which is used mostly in research circles, where you have infants that are sedated and then bag ventilated until you develop an apneic response when they're hyperventilated, and then there's a giant rapidly inflated blood pressure cuff that squeezes the air out of them, literally. Again, it's used mostly in research for cystic fibrosis as well as chronic lung disease of prematurity. In our laboratory, we can typically get kids that are 4 years old and above to do simple spirometry. Doing lung volumes, kids need to be a little older, both in terms of understanding the commands that are necessary to perform the maneuvers for lung volume measurement, as well as you have to have a minimum FEV1 that allows you to do the volume measurements. So typically kids 8 to 10 years of age can do these. Another important consideration in deciding who should undergo lung function testing are various disease processes. We have a number of obstructive diseases such as asthma, cystic fibrosis, chronic lung disease of prematurity, as well as a number of others. Restrictive diseases such as neuromuscular problems like Duchenne muscular dystrophy or spinal muscle atrophy, and then thoracic diseases like scoliosis. Finally, there are interstitial lung diseases. These are not really relevant to you guys, but they're important to us in pulmonary medicine, and we mostly address these looking at diffusion capacity, which we'll talk about in a minute, and then some vascular diseases as well. So why do we perform pulmonary function testing? First and foremost, to diagnose disease. Pulmonary function testing indicates the nature of the disease, whether it's obstructive, restrictive, or something else, as well as the severity and relative urgency of therapy. We also use pulmonary function testing to assess the response to therapy, and this includes both the disease that we're treating, such as asthma or cystic fibrosis, but also we are called on frequently to do pulmonary function testing to monitor lung function among kids that have a history of malignancy and have undergone chemotherapy or radiation therapy, because those can significantly and dramatically alter lung function. Risk assessment is a little less common in pediatrics. We do a lot of preoperative evaluations, but occupational environmental health is largely something that's done in adults secondary to workplace issues like toxic gas exposure or things of that nature. And then, very rarely we have kids that are going to be scuba diving or skydiving come in to be cleared for those types of activities. Also important to observe the natural history of specific disease processes, and there will be some illustrations later that make that point. And then also, and maybe more importantly, in the area of home spirometry, empowering people to engage in a lot of self-management. So where should pulmonary function testing be performed? There are any number of documents that are co-authored by the American Thoracic Society and European Respiratory Society that make recommendations for pretty much everything related to pulmonary function testing, or at least spirometry. An important thing to remember is that adult and pediatric spirometry are fairly different things. And in most cases, adult laboratories are not very good at doing lung function testing in kids. We have lots of kids every year that are referred to us for profoundly abnormal lung function testing that was done in an adult laboratory, and we get them here and we test them and everything is completely normal. There's a lot of talk right now about both primary care spirometry as well as home spirometry. There are a lot of people that believe that every primary care office in the country should have a spirometer, and that would certainly be helpful in terms of monitoring disease in a place where kids are spending more time than they are in our clinics. But there are a lot of issues related to quality control and maintaining training and proficiency. Sort of alluded to those above. So there are a lot of issues, and certainly not everybody is going to be prepared to do spirometry in a primary care office. And then we've done some home spirometry for specific populations. It is standard in post-lung transplant populations. It was done quite a bit in cystic fibrosis during the pandemic when people weren't coming to clinics and not doing spirometry in clinic. It worked fairly well in adults. It didn't work well in kids for a lot of different reasons. So those are some of the issues that are coming up these days. So the next question is probably one of the most important, and that is, what is pulmonary function testing? When a lot of people talk about pulmonary function testing, or PFTs, they are specifically referencing spirometry, which is really just the tip of the iceberg. As pulmonologists, we measure all aspects of pulmonary function. As allergists, you guys will probably be a little bit more limited in your scope, but I think it's important to understand some of these other concepts as well. So pulmonary function testing includes basic spirometry, lung volume measurement, diffusion capacity, as well as a whole bunch of other things that I'm just going to touch on really briefly later. This sort of pulls all that information together. We are looking at different aspects of pulmonary function: ventilation, diffusion, oxygenation, acid-base balance, control of ventilation, and then some special testing as well. And we do different tests to evaluate different disease processes. If these slides are not available to you guys, because I'm going to go through it fairly quickly, I'll talk to Chris and make sure that they're, sent out somehow. So the next W is, when should pulmonary function testing be performed? We've already talked a little bit about diagnosis, both the presence of the disease, the severity of disease, the character of the disease, whether it's obstructive or restrictive or something else. We do a lot of pulmonary function testing during exacerbations of chronic disease, more for cystic fibrosis than for asthma, but it's usually a good idea to check lung function during exacerbations of any type of chronic disease. And then, again, routine surveillance, which can be in clinics or home spirometry as well. So this is where things get interesting, is how should pulmonary function testing be performed. I alluded to the ATS and ERS guidelines a minute ago, and these combined guideline papers provide standards for just about everything, including performance, how to report pulmonary function testing, as well as interpretation. And we're going to go through all of those in a little bit of detail. So the standards for performing spirometry was last updated in 2019. The ATS, ERS have lots and lots of recommendations, which only become important if you are doing pulmonary function testing in your office. And if you are, you really need to be familiar with these guidelines and adhere to them fairly closely. In our laboratory in the hospital, we do this all the time. It's a little more challenging if you're in a private practice somewhere trying to maintain, again, proficiency and meet those standards. So again, more and more stuff about the guidelines. I underlined ethnicity here, and I'll touch on this a little bit later. When we come to predicted values and Z-scores related to interpreting pulmonary function. There are pages and pages and pages defining forced expiratory volume in 1 second and forced vital capacity maneuvers, and then reporting of values as well. This slide is not something you should even attempt to read or memorize, but all the indications for doing spirometry are things we've already talked about, but there are some relative contraindications that they talk about in these guidelines. There are a number of cardiovascular issues that would tend to suggest spirometry is not a good idea. Things that cause increased intracranial or intraocular pressure, sinus and middle ear disease can also be contraindications. Any type of intrathoracic or abdominal surgery are contraindications. And then for infection control issues such as during the pandemic, TB exposure, and a few other things. So these are the ATS-ERS standards for spirometry reports. Prior to 2017, most labs had very different reporting guidelines based on whatever software they were using or hardware they were using. And if you compared studies from, across the country, they all looked very different. So the ATS and ERS came out with this standardized report back in 2017, and they recommend a number of different elements. So demographics are important because those are used to determine percent predicted values as well as Z-scores. And again, I've underlined ethnicity here because just recently, the ATS and ERS have advocated for race-neutral percent predicted and Z-score values for spirometry. So we have adopted these in our lab, and are they're slowly moving out across the country. So eventually all of the percent predicteds and Z-scores will be ethnicity neutral. So the ATS only wants to see forced vital capacity, forced expiratory volume in 1 second, the ratio of those two, and forced expiratory time. I kind of take exception to this and like to see something called FEF 2575, and I'll explain why I have disagreements with the ATS and ERS in a second. Again, they want Z-score as well as percent predicted value, and these days they really prefer Z-score. Percent predicted is, I think, sort of a nod to us old people that have been looking at percent predicteds for, in my case, 30-some years. They want an evaluation of the quality of the study that was done. They want to see flow time curves as well as flow volume loops, and we'll dig into these a little bit more. They also came up with interpretation standards back in 2022, or 2021 rather, and they really, again, focus on a normal range, which is defined by Z-scores, as well as the use of these GLI equations across the world at this point for determining spirometry and DLCO and lung volume normals and predicteds. A quick word about this stuff. So normal used to be anything over 80% predicted for FVC and FEV1. Again, the new guidelines broaden that a little bit, and they're really talking about Z-scores. So normal is defined as between the 5th and 95th percentile for these Z-scores. Severity, we used to talk about several different severities, and this was, in truth, a little bit excessive: mild, moderate, moderately severe, severe, very severe, and they have thankfully simplified things a little bit, and are now using a three-tier score. There's normal, but then they talk about mild, moderate, and severe disease, which I think is much more reasonable. And then bronchodilator response is also defined. Used to be about a 12.5% change in FEV1 percent predicted, and again now they're really looking at a change of 10% in the predicted values, indicating a bronchodilator response. So what is this all about? This is a spirogram, which is the basis of everything that's going to follow. So it's important to remember that lung volumes are discrete elements that are then combined to come up with different capacities. So tidal volume is the amount of air that's moved in a typical respiratory cycle. So small volumes in and out. After you've taken a breath in, there is additional space and you can inhale more air, and that's the inspiratory reserve volume. Similarly, once you've taken a normal breath out, you can force out more air, which is the expiratory reserve volume. And then when you've gotten rid of all the air that you can move, your lungs are not completely collapse, there is a fair amount of air still in there, and that's called the residual volume, which is a very sensitive measure, particularly for obstructive lung diseases. So then we combine these volumes in different ways. Total lung capacity is all of the air in the lungs. Vital capacity is the amount of movable air. And then FRC is the combination of expiratory reserve and residual volume. And we don't use that a whole lot. So hang on for 1 second, guys. I'm sorry, we got a thing going on over here in the office. So basically you can look at spirograms to assess, again, normal function here versus restrictive disease, where you see decrease in all of those elements. And then obstructive disease, where actually your total lung capacity can be increased due to significant increases in residual volume. This is another way to look at that same information. Again, obstruction, you have massive increases in residual volume, which can only be measured doing lung volumes. It's not something you can obtain from simple spirometry. And then total lung capacity can actually be increased due to those major increases here. And then restrictive disease is just everything being a little smaller. So the next thing that the ATS talks about are these volume time curves. Again, we've got a normal curve here. We have got restrictive diseases where your FEV1 to FVC ratio is actually increased, and then obstructive diseases where that is decreased markedly. And these are sort of the patterns that these follow. FEV1 to FVC ratio is typically 80 to 85%. With obstructive diseases, these are both significantly decreased, but FEV1 really out of proportion to FVC, and as a result, this ratio decreases, whereas total lung capacity can increase. With restrictive, these are relatively decreased proportionately, although in this case FVC is more than FEV1, so that ratio is increased. This is a typical flow volume loop. It's comprised of an inspiratory loop. Hang on for 1 sec again. It is a complicated cola day. I'm going to have to go find somebody real quick. We'll be back in just a sec. All right, I am back and extremely sorry. So, flow volume loops, these sort of get the hearts of pediatric pulmonologists going pitter-patter. So we have the inspiratory portion right here, and we have the expiratory portion right here. So typically kids will take several tidal breaths, then they'll inhale as deeply as they can, and then exhale for as long as they can. We really pay attention mostly to this expiratory or exhalational phase because that's where we determine forced vital capacity and what's called peak expiratory flow or maximum expiratory flow. But there's other information in here regarding this FEF 2575, which I said is one of my favorite things. So this is a typical report from Children's Mercy Kansas City. We've got demographic information up here. We have height, which goes into the predicted values or z-scores. We have age, and we have sex. What we don't have anymore is race, because we have adopted those new race-neutral equations from the Global Lung Initiative. So really, everybody should be adopting Global Lung Initiative and then the updated race-neutral equations. So other things that show up on here are these volume time loop, or curves rather, that the ATS and ERS want, as well as the flow volume loops. We, on our printouts, show all of the attempts. So each one of these loops is a forced expiratory maneuver, and the computer picks the one it likes best, or the therapist can pick the one they like best, and end up putting that one over here. So these are some details from those figures. Again, we have a best value, which is determined either by the computer or by the therapist. We have the lower limit of normal and the resultant z-score. And then again, they've included percent predicted values for us old folks. They also demonstrate the same information graphically with the z-score specifically. So green is obviously good, red is obviously bad. So this is a normal FVC, a normal FEV1, and a normal ratio between the two. We have our volume time curve here, which actually gives you really good information. Volume here, time here, complete exhalation. So this is where airflow stops. So this is by definition your FVC. And then if this is 1 second, if we go back over to the y-axis, that is your FEV1. So you can actually interpret FVC and FEV1 from this particular figure. And then again, the flow volume loops. Our reports also include a table that has all of that information included for each of the attempts that was done. So this was a kid who apparently had to blow 10 times to get loops that the therapist thought were good. I told you I like FEF 2575. So to humor me, that's also in our reports. FEF 2575 for me is important because it measures what we call mid-flows, or the flow rates between 25 and 75% of the forced vital capacity. So this is a measure of small airway function and is really independent largely of effort and technique. FVC and FEV1 are very much dependent on the quality of the study, the amount of effort, and the quality of the technique, whereas FEF 2575 is more dependent on elastic recoil of the lung and is much more independent of quality and effort. The other thing that we include in our report are these trend studies. So this looks at the absolute values over time. So in a growing child, you want to see these continuously increasing. We also show these percent predicteds, and this is a kid with poorly controlled asthma. We have a pre-bronchodilator and post-bronchodilator several different times, and each one of these shows a significant bronchodilator response, and it's indicative of basically poor adherence with therapy. So I think these additions to what the ATS and ERS request are actually very helpful clinically. This is another one of those trend studies over time that shows the absolute values, and lots of study and lots of evaluations over here. This is actually a kid that had cystic fibrosis, and I talked earlier about sort of tracking pulmonary function over time to understand the life, the natural history of these disorders. So this child that was, sort of trucking along here, not actually growing, which is suggestive of poorly controlled or worsening disease. But then there was sudden sustained improvement, and this was when a specific medication was introduced to the market. This patient started on this medication, they had a significant and sustained improvement, and then our friend adherence came back, and we had some ups and downs based on adherence. We also talk about specific patterns in these flow volume loops. Again, this is a normal one. People talk about this looking like a sailboat, where you've got the sail up top and the bottom of the boat down here. You have a rapid, sharp increase and then a fairly steady decrease. Restrictive diseases are shown here, where again, the loops are just small, but they're normally shaped. We have obstruction, where you have these scooped out patterns on the exhalation part of the loop. We have these boxy squared off inspiratory and expiratory loops, which we see with fixed intrathoracic or extrathoracic obstruction. We have this exhalation only called variable intrathoracic obstruction, and we see that with things like tracheomalacia, sometimes with pulmonary masses or large lymph nodes, that kind of thing. And then we have this one where patient is not able to inhale as opposed to exhale, and this we see with things like vocal cord dysfunction. So it's important to remember this. We see a lot of kids sent in for asthma that don't have asthma, they have vocal cord dysfunction. Pre-post spirometry is also important. It's often done to confirm a diagnosis of asthma. Individuals who have obstruction at baseline and that 10% response to bronchodilator. This is the gold standard for diagnosing asthma. Again, the change was to 10% from the previous 12.5%, and this is based on predicted value, not the percent predicted like in the old days. This is, again, more pre and post spirometry. We include both of these in our reports. As you can see, this individual had some significant obstruction with 73% FVC and a markedly low ratio. And then post bronchodilator, we saw significant increases in volumes as well as the percents. So a very robust bronchodilator response. And these are the two loops. Again, severe obstruction, pre-bronchodilator, and still obstruction, but a lot better post-bronchodilator. So we do bronchoprovocation testing as well. One way to do that is exercise. We have kids come in, they do baseline spirometry, we put them on a treadmill with increasing rate and incline, and it's mostly used to diagnose exercise-induced asthma or bronchospasm, but it's also helpful for vocal cord dysfunction because a lot of times exercise will precipitate those episodes. Again, there are standard performance and interpretation guidelines from the ATS and ERS, and again, 10% change from baseline FEV1 is considered an abnormal response to exercise and diagnostic of exercise-induced bronchospasm. This is sort of a typical study that we do. Again, we have predicted values based on those Z-scores. We have baseline values here, and then we start running the kids and look for that 10% decline, and then we give them a bronchodilator and look at the response. So lots and lots of numbers. The therapists very nicely give us these graphs down here, which tell the same story graphically. This individual had a pretty significant drop and returned to baseline. So this would be considered a positive study. We also do methacholine challenges. We don't do these very much these days, but we do them every now and then. We do them when there is really a question about whether or not this is asthma or something else. And we also do them for kids that want to join the military. Asthma is a lot of times an automatic disqualification for some of the military academies. And we have kids that were diagnosed with asthma when they were 2 because they had recurrent coughing and wheezing. And that diagnosis is hung around long after they stopped having any symptoms whatsoever. So we will do methacholine challenges mostly to undiagnosed people as opposed to diagnosed people. And then these are the specifics of the study. We look at the concentrations and the dosage that we use, and I'll show you some examples of that in a second, and 20% drops in FEV1 are consistent with positive methacholine challenge. So this is the actual report that we use. Again, we report concentration as well as dose, and then the FEV1% change from baseline. So these are not very significant drops until you get to here. We also report the concentration that was given, as well as the interpretation of normal versus borderline versus significant, moderate, or severe airway hyperresponsiveness. And then again, we look at this graphically, and they help us out with the PC20 down here. We do a lot of lung volume measurement, mostly in cystic fibrosis. It's not typically something that we do in asthma or other allergic diseases that you're going to see. There are different ways to do it. This is something called helium dilution, which we do not do anymore because it's not very reliable. We do lung volume by plethysmography these days, and it's a complicated system to use. We basically lock kids in these giant plastic boxes and have them go through a number of maneuvers. Again, you guys are probably not going to be doing any of that. These are what those reports look like. And again, the thing that you get here is residual volume, which allows you to calculate total lung capacity. You do not get those with simple spirometry. And again, you're probably not going to need them. We do a lot of diffusion capacity as well. There's an equation that we use, and there are different methods to measure it. This is most helpful for interstitial lung diseases. And again, not something you guys would typically be dealing with, but we deal with it quite a bit. And again, these are the reports. These are all fairly standardized around the country these days. Other awesome things that we talk about. I am, madly in love with respiratory physiology. I'm just going to admit that. So we use something called the alveolar gas equation, which just allows us to calculate the partial pressure of oxygen in the alveoli. And that comes in handy in the ICU when you're figuring out severity of lung disease, oxygen carrying capacity, and then these Davenport diagrams. If you have any interest at all in acid-base balance, if you can, commit to memory a Davenport diagram, you can figure out any acid-base problem there is. The oxygen association curve is, again, something that we use a lot. It's a med student exam question, it's a pediatric resident exam question, and it's a pediatric pulmonology fellowship exam question. There are always lots of questions about that. And then there's a whole bunch of other esoteric stuff that you guys don't need to hear about. So those are the references that I used, and that's sort of what I had for you guys.